So good evening. Like I said, my name's Alika Lafontaine. I'm an anesthesiologist by training. Does anybody know what an anesthesiologist is? Yeah? Okay. Okay. If you've had babies, you usually like us around. If you need surgery, you usually don't. I grew up in Treaty 4 territory, Emoji Cree. Saskatchewan's known for three major exports: wheat, oil, and Albertans. So I'm living in northern Alberta now. And been in Grand Prairie for about 6 years. I have a full clinical practice there at a community hospital, and then I do a lot of volunteer work with Indigenous health. My remarks are going to be split into two parts. So tonight we're going to talk a lot about context, and tomorrow I'm hoping you guys are around to talk about what we literally have done in order to bring together 150 First Nation communities from across Canada into a project that helps us to contextualize and put together a bit of a work plan on how to fix some of the problems in our communities. I think it's important when we talk about Indigenous health to realize that the context that we come to our communities with, First Nation communities, Métis and Inuit, is a lot different than the living reality there. There's a lot of things that we expect to be there, things that we take for granted in the public healthcare system and in general for Canadians that just don't exist on reserve. And there's such a big gap between those things that sometimes it's hard to actually see what's really there. So years ago, I had an elder sit down and go through a concept with me that I'm going to share with you just to frame my remarks at the beginning. I'm going to go into a bit about colonialism. I think a lot of the discussions that we have about colonialism aren't really practical discussions. They don't lead us towards doing something. And at the end of the day, it's not worth learning about something, at least from an anesthesiologist's point of view, unless you can literally do something about it. And then at the end, I'll talk a bit about how closing the gap in health disparities, why it's been unsuccessful and how we can be more effective. So scotoma is probably a concept that you guys have heard about before. Scotoma is something that you often see as a partial loss of vision or a blind spot in an otherwise normal visual field. And it can happen for a lot of different reasons. Neuromuscular diseases, including things like strokes, neurodegenerative diseases, sometimes trauma can cause scotoma. But there's also something called an intellectual scotoma, something that's right in front of you but you can't actually see. So I assume everybody here knows what the letter F is. I'm going to have you just count the F's in the next paragraph. There's no trick here, just count the F's. And after you count the F's, we're gonna see how many you see. All right, so I'm going to give you 3 seconds, all right? So paragraph up here, read it quickly, I don't count too fast. And here we go. 1, 2, count all 3 F's. How many were there? 3? Okay, so we'll pause right here. How many people saw 3 F's? Raise your hand. How many people saw 4 F's? How many people saw more than 4 F's? Okay, so this is actually a normal distribution. So I heard quite a few people kind of yell out 5 F's, other things. So these are the actual F's inside the paragraph. So finished files of, scientific, and of. So I presented this at hundreds of places across the country. And the distribution is almost always the same. About half of the people see 3 or less. A smattering of people see 4 or 5. And then very, very few people ever see 6. All right? So this is actually a very famous visual trick, and there's 2 reasons that are given in the literature about why this happens. The first is that even though I told you just to count the F's and there was no trick, a lot of you were probably reading for content, right? Especially once you saw scientific, I'm sure. So no matter what we do, we always try and read for content, and when we read for content, we usually read auditorily. So I'm sure lots of you were thinking in your head, finished files are the result of your scientific study. So when you're reading, scientific sounds very different than of, okay? So the first one is the auditory reason. The second reason is that when we're given limited amount of time and we're looking for content, we look for the big words. We skip over the ofs, the as, and the thes, okay? So that's the second reason. What's your name?
Louise.
Louise, do you mind standing up for me, Louise? All right. I'm gonna have you help me out with this, okay? So I want you to count the triangles. Once again, there's no trick. There's gonna be 3 triangles, 1, 2, 3. Just yell it out really loud and just read all 3 of the triangles as quick as you can, okay? Understand?
Read the triangles.
There's going to be words inside the triangles. I want you to read them really loud, okay? And just go 1, 2, 3. So let's just try your projection. See how loud you can get.
Oh, I'm going to read the triangles.
Okay, you guys can all hear that? Do you want to be maybe just a little bit louder? Can you try that again? I'm going to just say I'm going to read the triangles.
I'm going to read the triangles.
Okay, perfect, perfect. All right, so we're going to go 1, 2, 3. First one.
Person's ring, bird in the hand, once in a lifetime.
So is that what it actually said?
Oh, person in the dust ring. Bird in the dust ring, once in a lifetime.
Okay, thank you very much. Thank you very much. All right. So this is a very interesting thing about intellectual scotomas. I just told you that you don't see something up there. I just told you that you skipped over small words. And you still immediately did it, immediately after I laid it out for you. And this is the way that we think about things. It's interesting with these two exercises because if you do it with kids who are less than grade 5, all of them get it right. Okay? You cannot trick a grade 4 or lower with these two exercises. And it's because they haven't gotten to the point where they read things in their head auditorily. They haven't gotten to the point where they're reading for content instead of following instructions. And they just refuse to skip over words. What it also doesn't work with is adults who haven't passed grade 5. All right? So for whatever reason, we in our educational system develop these ideas in our head about how to read. All right? Now, this is also true for a lot of other things as well. All right? This is true for researchers. This is true for anesthesiologists. This is true for physicians in general, nurses, pharmacists, all these different people in the healthcare system. When I get into certain situations, I think and expect certain things to be there, and I can't always see what's right in front of me. So we use scotoma things every day. Diagnosis, screening, intake protocols, etc. They're all forms of creating this bias, this scotoma. And I'm going to call this profiling, because this is really what profiling is. As I look around the room, I can already tell you which one of you are going to be difficult IV starts. I know that already. I know which one of you I'm going to pull out the difficult airway card. I know which one of you I'm going to expect to have blood pressure variations. And already my mind is going, before I've even talked to you about anything, that I need to prepare this way or that way if I see you in the operating room. I expect it's the same for pediatric endocrinology. I expect it's the same for researchers. I expect it's the same for community members. You see certain patterns and you expect to come across certain things, so your mind starts going. Now, this is actually very important, and it's actually useful. You know, it's integral to our work as clinicians, medical administrators, and researchers. If we can't see patterns, it's impossible for us to work quickly. And if we can't work quickly and we take too long, time is money, time is lost opportunity, time is possible patients dying. Now, on average, and they've done studies of this in Harvard, Yale, and other major Ivy League institutions, 18 seconds. That's how long it takes you. And when I read those studies for the first time, I actually started timing myself, and it's about 25 seconds before I've already decided what's going to happen when you come and see me in holding. Now, there isn't a problem with this as long as we start to take in other things, start to take in other information to help us understand what's going on. So information that I'm referring to are things like medical history, physical exam, ordering blood work, requesting x-rays, other special tests that either confirm or refute our original 18-second assumption. So we often call this our working diagnosis. I'm not sure what the equivalent is for researchers. Maybe this is your thesis statement. Maybe this is your null hypothesis. But this is where you're starting. This is where you think things are going to go. Now, there's an 80-20 rule that's come out of health systems research that shows that when we apply things like this, 80% of the time it ends up working for most patients. And it actually works quite well. 20% of the time it creates a lot of harm and actually really, really harms patients. And this is true for hypertension guidelines, this is true for research protocols, this is true for anesthesiologists assessing you and holding. So the question that I'd like you to think about is there systemic bias, racism, and discrimination in health? And is it the core reason why Indigenous health disparities persist?
Yes, I have experienced racism in the health system with the doctor here and nurses. You know, nurses treat us differently. My file, every time I go there, like, I'd be there before everybody, and I thought it's first come, first serve. But my thing would get, my file would get put to the bottom. You know, I'd have to wait there all day, and you know, I'd be trying to talk to one of the nurses, or talk to the doctor. You know, then they'd tell me, go sit down, like telling me to go sit down like a child. You know, I'm not a child, and then not wanting to speak to me, and then I see someone goes up right after me, like another patient. And they talk to one of them right away, and like they tell me they're busy, and that's with the doctor and nurses that they do that. Well, for one thing, I'd like a different doctor. Plain and simple, a different doctor, and also better training for people skills for the nurses. They seem not to have any people skills, They get grouchy at us. The woman that sits at the desk that takes some names and, sets us up, she gets grouchy with us. When I was there 2 weeks ago, I heard her swear and say effing natives. I heard that. I was sitting right there in that chair. She kind of whispered it, but I heard it. I heard it clear enough to make out effing natives.
Well, I know when my mother was in the hospital, she had diabetes, and she had, like I said, heart, kidney, and lung problems, and she was in the hospital for about a month or maybe even 2 months. And when I went to visit her, she didn't have no sheets on her bed. They told me that she was on a mattress that didn't need sheets, but when they finally came to check on her, it was not that kind of mattress. And my mother wouldn't say anything. She wouldn't make any kind of fuss. She just laid on the rubber mattress, and that's it.
I'm a diabetic, and the one you're talking about, he likes touching women. He even done that to me too. And I used to wonder, is that possible for a doctor to do that? Eh? He slipped his 2 hands into my panties, but didn't touch my private. He done that from the back to the front. Eh? Boy, I was amazed, and he just threw himself on the chair after he done that, and he was just blushing, just red. Eh? I just about swore at him, but then again he might charge me. I should have swore at him at the time. I tell him the same thing what I experienced with him. Are they going to do anything about it? Like that. You know the time I broke my knee? And then when I was there for 5 days, and the nurse was coming to give me 4s, and then I told her, can I get a Tylenol extra strength instead of it? She got mad at me, and she went back to that word she keeps her pills to come and give me that Tylenol thing. And she holds my lips and then puts that pill into my mouth roughly. And I told the other nurse to put my leg on that pillow. She lifted my leg, put that pillow there, and just dropped my leg again. I was just being treated. If I was able to walk, I said I would have walked out of there. And I told my auntie, though, she gets the same treatment.
Well, a lot of old elders don't feel safe there. Like, I see elders when they're in a hospital. Like when I go up there from my town, I talk with them. They don't feel safe. They look scared, but they don't want to say anything. But they look scared, and you can feel that on them. And that shouldn't be these are our elders. They shouldn't be feeling scared like that. That's a place they should feel safe.
Kinds of things should happen. We should have proper diagnosis. We should have First Nation people at the doctor's office, the drugstore, throughout the system there. We should have a place for concerns to be heard, anonymity, and also online questionnaires or something to that effect, where a person can actually just sign in and say this is what happened to them.
He's the only doctor we can see, so Like, what if we're really sick one time and he doesn't want to give us treatment because of that? And he will do that.
And that nurse there, that receptionist at the hospital, she used to be very friendly with me. Now I'm mad to her, I guess. For what, I don't know. You should see the way she treats them, eh? Very negative and looking angry. I just about told her the last time, why don't you quit your job if you don't like working for Indians? I just about said. I will do one of these days.
So that's not an easy video to watch. It wasn't an easy video to make either. That was from 3 patient interviews that I held with patients out of Saskatchewan 2 years ago. And they actually each went on for about 45 minutes about their experiences in the health system. How often do we hear those stories and say to ourselves, that must be a one-off. That could never happen in Canada. There's no way that a physician or a healthcare provider could cause that sort of harm and nothing happen. Now, when I present this, and I presented this across the country to physician groups and groups such as yourself, one of the things that I always tell the groups is, I know no one in here wakes up and says, you know, it'd just be a great day if I could just harm an Indigenous patient. That would just be the best day. You know, I know in your research you don't write protocols in order to create harm. I know when you're participating in expert committees in order to establish guidelines, that's the last thing on your mind. I know when you refer patients into patient streams who all go to the same doctor, that's not what you want. But that is what happens. You know, I've worked across the country and talked with physicians across the country about these things. This is the lived experience of our First Nation, Métis, and Inuit patients. This is happening, and we don't talk about it. And patients are terrified. You know, as an anesthesiologist, you have no power once you get into the hospital. I'll tell you that right now. As soon as you're in my operating room, if I don't want you to talk, I'm going to give you drugs and put you off to sleep. If I think you need surgery, I'm going to get a 2-physician consent. If I want to have you sit in holding for 2 hours while I go off and have lunch, I'm going to pretend like I'm in ICU. This is the kind of power that we hold in the health system. This is the kind of power that we hold as researchers, as clinicians, as health administrators, as policymakers. We hold all the strings, and patients don't have any of the power. You know, the patient-centered care revolution that's happening right now is probably the most important thing that's happened in medicine, in the history of all medical care. But we still have to cede that power. And how often do we cede that power to our First Nation, Métis, and Inuit patients? You know, one of the things that we often have is, you know, these set of myths and beliefs and biases about why things happen. I had a discussion with a surgical colleague who's a fantastic surgeon, very caring, know he takes time with his patients, know that he wants the best for patients. But our conversation led off with, you know, if only those natives from up north didn't just come down for a free ride and skip their appointments. You know, and it just so happened that in my role with Alberta Health Services, I actually knew what happened with that transport. It had nothing to do with the patient. You know, the van wasn't full enough, and so the van didn't leave from the reserve that was at because someone in Ottawa decided that it was a waste of money, and no one informed the specialist that was supposed to be seen. But often we go back to these biases that, you know, First Nations people are lazy. They don't care about their health. You know, they use health services at a higher rate just 'cause. You know, there's the story of Brian Sinclair and the death that he had from urosepsis. How many of you read through the 191-page inquest report? Because there's a lot of detail in there that never came out. Brian was actually going and getting his catheters changed somewhere else, and the nurse practitioner who decided that he was skipping his appointments just stopped seeing him, even though he had to go more frequently. And why did he have to go more frequently into hospital to get his catheter changes? Because First Nation Inuit Health Branch wouldn't supply him more than 10 catheters per month. So the only way for him to access it was by literally going to a doctor's office. You know, imagine yourself as a paraplegic having an ongoing urinary tract infection, and it's so painful that you have to go in to a location in order to get new material because the programs that you're accessing don't provide you more, and there's no scientific basis to giving 10 catheters per month. You know, and you develop this urosepsis, you show up to emergency, and everyone thinks that you're just a drunk. You know, 18 healthcare providers well-meaning healthcare providers that went into work wanting to save lives that day. Because of the narratives that we create about Indigenous patients, made a mistake that cost him his life. But this cuts both ways. And I think this probably applies to researchers and the frustration that you guys often feel when trying to engage with First Nation communities, Métis communities, Inuit communities. You think that maybe they're just not interested. Maybe you get frustrated once they get into the research protocols that, they tend to be more upset or more angry. I've been yelled at by Indigenous patients, and when the yelling is over and we start to unwind, I realize that that's the very first time that they've ever felt empowered, ever coming. It's the first time they ever felt like they could yell at anybody, and all of their frustration just came out in that moment. It had nothing to do with me. As researchers, you probably feel increased frustration. You don't understand why these simple situations are becoming more complex. You get stress and discomfort when meeting with Indigenous patients because you're not sure what's going to happen, or you expect bad things to happen. Your morale within your team starts to sink because you're thinking, I'm pouring all this effort in to try and make a difference, and nothing's happening. For many researchers and clinicians, there's increased complaints and boundary violations, from both sides. And eventually sometimes concern about litigation and burnout. People just don't want to participate with certain demographic populations just because they're afraid of what will happen. On the side of patients, there's decreased patient compliance. You probably get a lot of attrition from patients who drop out of studies, increased risk of conflict, sometimes misdiagnosis, increased morbidity, and then increased mortality. So the big question that we tried to answer in our project is, why does this persist? We've spent hundreds of millions of hours, people hours, on this problem for 3 decades. Smart, intelligent, well-meaning, motivated individuals like yourself have poured their lives into helping Indigenous health disparities narrow, and they keep on getting wider. Today on CBC News, they published a report that HIV is 800 times normal, the normal mean for HIV rates in Canada. 800 times more. That's almost 100% permanence in the populations that they're talking about. We talk about diabetes being 5 to 7 times higher in Indigenous populations. In some communities, it's 100%. I regularly have patients who come in who've been on insulin and that dose hasn't changed for 12 years. That's impossible. It's impossible for insulin doses not to change over a 12-year time span. Others come in and they laugh and say, oh, look, my glucometer is reading unreadable again. That's over 40. That's a glucose over 40. So when I talk about colonialism, it's important to understand that Canada was built on these outcomes for Indigenous social health and education programs. Colonialism isn't something that I think anybody in government believes in anymore. It's not something that we really want for our patients anymore. Murray Sinclair from the TRC and now a senator, he probably gave the most succinct definition of colonialism. And he said that colonialism is the intent to extinguish the rights of Indigenous peoples to land and resources. That was the whole reason these colonial structures were put together. And if you read through the historical research, particularly how health systems evolved for Indigenous peoples, you actually literally read about papers going back and forth, letters going back and forth, where the government talks about creating public health programs in order to protect towns and cities from getting sick from the native population. That's why First Nation Indian Health Branch is built on public health. It's been reframed different ways, but it was never to ensure that there was a population health approach. It was to ensure that non-Indigenous populations didn't get sick. And it makes a lot of sense if you think in the frame of colonialism, because there's 3 real ways to get rid of someone's rights. If I want to take your car from you, I can make it so you can't drive, I can make it so you leave it behind, or I can kill you. Those are the 3 most effective ways. And what are the outcomes of our Indigenous health system? There's big changes that are happening right now. There's acknowledgement and truth-telling of the assimilation, cultural genocide, deliberate genocide that's happened in certain regions of the country, and a realization that these were not the ends. The ends were to extinguish rights. These were just tools. They were just convenient tools that were utilized. And an understanding that our systems, if they were built upon these intents, they evolved in a way that you can't really get equity and equality in health. All of us in this room, we have certain health rights. There's certain inherent health rights. When I walk into a clinic here in Toronto, I can expect the same sort of health care that I receive when I walk into a clinic in Grand Prairie. But the reason why it exists that way is because we have certain health legislation that frames those rights. In Manitoba, there's more than 40 health laws, public health acts, vaccination acts, health professional regulatory acts, acts that frame and sandbox what you can and can't do. On reserve, none of those have effect. There's literally no health act on reserve. So while here in Toronto, I can expect that I can be investigated and diagnosed by someone who's licensed and competent, and that there's some sort of complaint mechanism in place if I have a bad experience. There's some type of quality improvement program to make sure that person is continuing to get education. There's some type of oversight to make sure that they're not just operating in isolation from everyone. That doesn't exist on reserve. It literally does not exist. And we finally have a Minister of Indigenous Services who's actually coming out and saying these things and saying them out loud. This is the lived truth that we've heard from our communities for decades. But because we were scotoming, because we were applying our own lived experience to what they were going through, we just didn't hear it. When I give this talk, it's usually a bit truncated, that way it's not totally depressing. But I do think, and I strongly, strongly believe this, that we're finally at a point where the status quo is not an option anymore. People are dying at too fast a rate. People are too sick in order for them just to sit and say nothing anymore. We have people like you in this room who care too much and who are too motivated to make sure that this doesn't persist anymore. We're finally getting a reforming of structures. Minister Bennett, her intent is to dismantle Indigenous and Northern Affairs Canada. Shifting our health minister over to the Minister of Indigenous Services. And whether or not she can pull it off, I don't know. I do know Philpott is a very, very competent physician and a very, very competent minister. We're changing structures. We're re-exploring where we came from and what we were trying to do, and deliberately trying to reform it into something different. But I guess the advice that I have for you tonight is that when you hear things, like when Desmond was talking about, one of your challenges is that, people don't want to just let you use their boat. They need money for it. One of the first things that we often hear is, oh, well, they don't want to volunteer their time. They're not interested in helping their kids. They don't want to spend the $5 to pay for gas. Well, that $5 may literally be what's keeping the heat on in the house. There's no food bank on your First Nation, I expect. There's no homeless shelter. You don't have access to the social or other safety net programs that we usually have. There's no charities in your community that are making sure that you have money to pay for the $20 of gas that you need. And our research funding is structured in a way that you can't really pay for gas out of a research budget, even if it's only $10. You'll lose your funding if that happens. So in your discussions today, one of the things that most impressed me was the collaboration and the sharing of knowledge that you had here. But what I encourage you to do when you share that knowledge, and it's very powerful knowledge that you've collected together, sit back and ask yourself, do my rules apply in this situation? Because I can tell you most of the time they probably don't. And if you can approach your challenges that you have with engagement, communication, community partnerships, understanding research data that doesn't seem to make sense, you're going to find enormous insights that are going to change the way that you provide research and eventually influence clinical care for our Indigenous patients. I'm very hopeful because I'm able to have conversations like this. Even 10 years ago, I couldn't give this presentation. I'd have everyone in the room standing up saying, you know, this just doesn't happen in Canada. This just couldn't happen. But now people are mindfully sitting back and asking the question, could this happen? And if it does, am I just not seeing it? I'm really proud of the work that the Lawson Foundation does. I'm proud of the work that you guys do. Like, I've read through the handout with the description of all of your projects. If I was more research oriented, or I guess a bit smarter, I could see myself involved in some of these projects. We need people to be out there doing these things. We need you to engage with our communities. We need you not just to listen, but to really hear and to really understand. Maybe don't count the homeless if we tell you that we're homeless. If we tell you that people are dying, maybe don't arrange for funding to do a study on mortality over the next 2 years. Maybe just trust us that we know what's going on. And I think if you can do that, we're going to have a very, very bright future together. Thank you.